Okay, so for the optic atrophy, we have different kinds of optic atrophy. We have the primary optic atrophy, which is an optic atrophy which is not preceded by optic disc swelling. Primary optic atrophy, you will find that it has a well-defined margin and it is whitish like that. So this is called primary optic atrophy, whitish optic disc and well-defined margin. This is in contrast to the secondary optic atrophy. Secondary optic atrophy means that it was preceded by optic disc swelling. And the optic disc swelling, you can see that there is a still blurred margin, and the optic disc is a little bit dirty grayish, and there is a little bit of obscuration of the blood vessels at the disc margin. Other kinds of optic atrophy, it is the consecutive optic atrophy, which was secondary to a retinal disease, such as consecutive optic atrophy secondary to retinitis pigmentosa, as we can see here. There is also the glaucomatous optic atrophy, which is secondary to glaucoma, and hereditary optic neuropathy, or hereditary optic atrophy secondary to hereditary optic neuropathies, such as Leber hereditary optic neuropathy. In Leber hereditary optic neuropathy, it is one of the hereditary optic neuropathies that are present usually in the second to third decades, present with optic disc swelling and the peripapillary telangiectasia, as we can see here. And can see this is optic disc swelling, and with later on the disease progressed and eventually there was an optic atrophy. So this is a hereditary optic atrophy. For those patients, smoking is a very important risk factor, and that should be prohibited. Okay. Now let's move to the congenital anomalies of the optic disc. So the first congenital anomaly of the optic disc is the optic disc drusen, or optic nerve head drusen. In the optic nerve head drusen, we will find that the optic disc has a regular pattern. Dr. Ahmad Khader, optic disc swelling of papilledema need at least 6 weeks to be regressed after treatment. Is it true? It will, are you saying a regression or complete resolution? No, for regression, it can regress much better, much earlier than that. I see cases which had idiopathic intracranial hypertension, and I saw improvement in 1 to 2 weeks. So you should expect to find an improvement in the optic disc swelling in 1 to 2 weeks. No, 6 weeks is too much. You're welcome. Okay, so for cases of optic nerve head drusen, those patients have irregular optic disc margin. They have lumpy appearance of the optic cup of the optic disc. This is due to calcium deposition within the optic disc. So actually, drusen is a kind of calcium deposition. So how can we say that this is not a true papilledema? By presence of this lumpy appearance of the optic disc, there is no obscuration of the blood vessels at the disc margin. And the most important sign here, which is almost pathognomonic for the optic disc drusen, is this abnormal bifurcation of the blood vessels. You see this blood vessels, this is not like the normal bifurcation of the retinal arteries, central retinal artery and central retinal vein. So this is highly suspicious of the congenital of the optic disc drusen. In order to confirm your diagnosis, those patients can be asymptomatic, can also complain of headache, and they can show a visual field loss, and they can show transient visual obscuration. And when they also, a large number of them have a positive family history. So you need to check also other family members. When you do investigations, you do on the fundus autofluorescence, you can see that the drusen can show hyper autofluorescence on the fundus autofluorescence. And on the UV, in the ultrasound, it can show hyperechoic lesion present at the, with back shadowing present at the optic disc head. And on the CT scan, you can see this is like hyper dense lesion present on the CT scan. So let me ask you a question. If you are in the MCQ exam and they ask you if you have a child with optic disc drusen and you want to confirm your diagnosis, which one will be better to do, ultrasound or CT scan? What do you think? So why do you prefer the ultrasound? Yes, exactly. You want to minimize the risk of exposure to radiation for this child. That's correct. Exactly. Okay, perfect. So let's check for the other congenital anomalies. Other congenital anomalies that are asked frequently also in the exam are the optic disc globomas. In the optic disc globomas, it will be a large excavated optic disc like that. You can see that there is optic disc above, but there is loss of the optic disc tissue below. This is a large excavated optic disc and is usually inferior or infranasal, can be also associated with chorioretinal globomas and commonly to be associated with retinal detachment, or it can be associated with high risk of retinal detachment. Differential diagnosis of optic disc globoma will be the morning glory syndrome. In the both of them are similar in that both of them have large excavated blood optic disc. However, in the optic disc globoma, there will be loss of the part of the optic disc, which is here in the infranasal. However, in the morning glory, there is no loss of the optic tissue, of the optic disc tissue, but there is radiating blood vessels. You can see that the blood vessels are radiating from the optic disc in the same way like the sunset. Like that's why it's called the morning glory syndrome. There is ring of abnormal chorioretinal tissue or abnormal chorioretinal pigmentations like that. And there is a central white tuft within the optic cup. So for those who are applying for the clinical ICU exam, morning glory syndrome is very hot topic in the clinical ICU exams. Optic disc pit, it will be presented with a round or oval, which is usually temporal. So don't confuse between the optic disc pit and optic disc globoma. Optic disc pit is usually temporal. The defect is usually temporal. In the optic disc globoma, the defect is usually inferior or infranasal. And this defect will lead to leakage of subretinal fluid into the subretinal space, which will be associated with central or serous macular detachment. So for if we have a patient with optic disc pit, we always need to check for the macula for the presence of central macular detachment. And that's why those patients may present with a central scotoma because of this macular detachment. So optic disc pit can present with enlarged blind spot or any other visual field defect, and the macular detachment will lead to central scotoma. Patients with optic nerve hypoplasia, those patients can have what's called a double ring sign. So the optic disc will be very small and present with what's called a double ring sign. This is essential for optic nerve hypoplasia. And optic nerve hypoplasia, when it is associated with absence of septum pellucidum, this is a syndrome called the De Morsier septo-optic dysplasia. De Morsier septo-optic dysplasia is a syndrome where there is absent septum pellucidum and optic nerve hypoplasia. There will be ectopic pituitary leading to what's called hypopituitarism and no corpus callosum. So this is also very frequent topic in the clinical ICU exam. So when they are presenting to you a CT scan or asking about or showing you an optic disc hypoplasia, asking about the association. So you can see this is the corpus callosum here. And this is the septum pellucidum. And there is here no septum pellucidum and the thin, very thin corpus callosum. Those patients have optic nerve hypoplasia. And you can see this is again no septum pellucidum here. So it's called the De Morsier septo-optic dysplasia. Dr. Islam, what I'm saying to you now is the most common congenital anomalies. It is the optic disc head drusen, the optic disc pit, the morning glory syndrome, the optic disc globoma, and the optic nerve hypoplasia. These are the commonest congenital anomalies. Okay, everything is clear so far? Okay, great. Yes, liver. Okay, so we said important hints about liver hereditary optic neuropathy. So we said that in liver, so let me summarize the liver hereditary optic neuropathies. Those patients are presenting with bilateral optic neuropathies. This is those patients are present with, let me show you here. Those patients present usually from the second to the third decade. They present with bilateral optic neuropathies. Usually they are sequential, meaning that they will start one eye, then followed by the other, usually proceed with few weeks later. Usually those patients present with visual acuity of around 660, and then the other eye will progress. The important sign here is, or what's characteristic about the liver hereditary optic neuropathy is the peripapillary telangiectasia. So you can see that there are peripapillary dilated blood vessels, which tend to disappear later on when the patients when the condition progresses to optic atrophy. Those patients, it is more common in males because it is mitochondrial inheritance. This is also important, asked in the exams. It is mitochondrial inheritance, and it was found that the smoking is associated with increased progression of it. So smoking should be inhibited or prevented in those on those patients. You are welcome. Okay, so let's get started with the next case or next topic, which is the chiasmal syndrome. So what is the chiasmal syndrome? It is the optic chiasma. Optic chiasm, you know, this is the optic chiasm. And by knowing, by saying chiasmal syndrome, it is any lesion that will cause compression on the optic chiasma. Again, any lesion that will cause compression on the optic chiasma will cause chiasmal syndrome. So what are these lesions? The most common is a pituitary adenoma. So here is the pituitary. What is the relation of the pituitary to the optic chiasma? Here is the pituitary, and here is the optic chiasma. So the pituitary gland lies below the optic chiasma. This is called hypophysis cerebri, and it will cause compression of the optic chiasma. So this will lead to damage to the chiasma. And since that the pituitary adenoma is one of the commonest intracranial tumors, this will be by far the most common cause of the chiasmal syndrome. Other causes will be meningioma, craniopharyngioma, glioma, or it can be due to multiple sclerosis, sarcoidosis, and tuberculosis, pituitary apoplexy, aneurysm, and atherosclerosis, post-trauma or surgery or post-radiotherapy. So you can see a lot of reasons can cause chiasmal syndrome. But for the exam, the most important asked is the pituitary adenoma by name. So why? Because pituitary adenomas are the commonest cause of the optic chiasma compression in adults. It was found that it accounts for 12 to 15% of symptomatic intracranial neoplasms. So those numbers also come in the MCQs, so focus with them. Pituitary adenomas, you can see this is the sagittal section and this is the coronal section showing a pituitary adenoma compressing on the optic chiasm. So what will be the symptoms of patients with chiasmal syndrome? So we are speaking now about pituitary adenoma. Well, it was found that around 45% of those patients will complain of headache. But is the headache the same headache of increased intracranial pressure? Actually, no. The headache is not due to actual increase in the intracranial pressure, because it will be unlikely that this tumor will reach a huge size until the patients complain. The patients will complain much earlier from the pituitary adenoma, either from the visual symptoms or from endocrinological symptoms if the patient has secretory pituitary adenoma. So why the headache occurs? Well, the headache occurs mainly due to mass effect. So there will be there will be enlargement of the pituitary gland, leading to stretch on the surrounding meninges, leading to pain. So this stretch, that's what will result in the pain. Decreased vision, those patients will have decreased peripheral vision or peripheral visual field due to compression of the nasal fibers, the decussating nasal fibers, leading to temporal hemianopia. Those patients will complain of what's called loss of the depth perception or post-fixation blindness and the hemifield slip. We are going to discuss this in the next slide. And also will complain of diplopia due to involvement of the ocular cranial nerves in the cavernous sinus. You can see this is the cavernous sinus. It is present on the lateral aspects of the pituitary gland, and this is the chiasmus. So if there is a pituitary adenoma here, it can involve the 6th nerve, the 3, 4, the trigeminal nerve. All these can be involved due to pituitary tumor. Okay, so this is for the diplopia. So diplopia can be due to paralytic strabismus or paralytic squint, leading to causing involvement of the 3rd or 4th or 6th, or it can be due to what's called again hemifield slip. So what is hemifield slip and what is post-fixation blindness? Concentrate with me. Post-fixation blindness, just think of the word post-fixational blindness, meaning that the area behind the fixation is blind. When the patient is looking to a near target, then the area behind this near target will be blind. So why? Because of the blind temporal field. So let's read it now. It is abnormal depth perception with closed work convergence, resulting in crossing of the blind temporal hemifields, and therefore image posterior to the fixation will fall on the blind temporal field. This will cause difficulty with tasks like precision tools, like reading. So this is what happens. When a patient look at a point like here, at point T, so this is the macula, M and the M. So when the patient is looking to a near target at T, what will happen? This is the temporal field, and this is the temporal field. And this patient had, as you can see, this yellowish is temporal to the macula, and this bluish field is temporal to the macula. And when the patient is converging his eyes to look to a near target, this will lead to overlapping of the blind fields, the temporal blind field of both eyes. And this will result in, if this any object behind the book that he is reading here, he will be having a difficulty to appreciate the depth, the perception of depth between the book and this target, leading to abnormal depth perception because of the blind temporal field. Okay, so this is one reason why the patient has abnormal depth perception. This is a post-fixation blindness. Another problem that also can affect the patient's ability to read is the diplopia. So it could be vertical or horizontal. Why? First of all, we said the paralytic due to involvement of the ocular cranial nerves and the cavernous sinus. And the second reason is the hemifield slip or slip phenomenon. So basically, when the patient is looking to any target, there will be overlap between the temporal field of one eye to the nasal field of the other eye. So there will be overlap between the right temporal field and the nasal left field, and the right nasal field and left temporal field. So for those patients, there will be overlap of the temporal field of one eye and the nasal field of the other eye. But what happens? This temporal field is blind again. This temporal field is blind, so the patient will not be able to overlap of this blind temporal field to the nasal field of the other eye. So this overlapping is essential for fusion of the images. And since the patient is not able to do this overlapping, this will result in again diplopia and a difficulty in reading. So these questions appeared before in the advanced ICO exams and appeared in the FRCS3 exams, why the patients with chiasmal syndromes are unable to read, or why he is experiencing a difficulty in reading. Again, due to post-fixation blindness and due to diplopia. And the diplopia is due to hemifield slip and due to paralytic strabismus. Okay, so this is the chiasmal syndrome, and this is the post-fixation blindness. So what will be the signs? And here, please or pay good attention to this, because every word here is very important. First of all, the patient has, in the vision, the patient can have affected visual acuity or preserved vision, depending on what? Depending on which part of the optic nerve or the chiasma is involved. Like if the chiasma is involved, the lateral aspect of the optic, the nasal fibers, so this patient will have bitemporal hemianopia, that they may not be, or they may not complain of the central vision. But if the tumor is involving the central fibers, like if they are involving the macular fibers in the chiasma, as they are decussing posteriorly, or if they are involving the optic nerve itself, this will result in affection of the vision. So it is not a rule for patients with chiasmal syndrome to have affected vision. The color vision, those patients will have what's called red color desaturation. And this can be tested by the confrontation test. So when we are bringing a target from temporal to nasal and asking the patient whether they can see it red as a bright red or it is a washed out red, they will say that it appears as washed out red in the temporal field and appears as bright red in the nasal field. So why does this happen? Because of the compression of the nasal fibers, which represent the temporal field. And again, you will find the neuro-ophthalmology examination course. It was free. You can check it for the how would we do a red color desaturation test by the confrontation test. For the confrontation test, it will show the visual field defect, which will be classically a bitemporal hemianopia. The pupil can show a relative afferent pupillary defect. The optic disc will show band atrophy, and I discussed it in the first lecture. So we said that in those patients, they have compression on the nasal fibers and compression on the central fibers. These are the nasal fibers, which will end in the nasal quadrant of the optic disc, and the central fibers are representing the papillomacular bundle, making the temporal quadrant of the optic disc. So compression of these fibers will result in temporal and nasal pallor, resulting in what's called the band atrophy or bow tie, horizontal bow tie atrophy. For those patients as well, they have a very important sign that asked very commonly in the MCQ exams, which is called the seesaw nystagmus. The seesaw nystagmus is a patient who has nystagmus in which one eye elevate and intort and the other eye depress and extort. It is high frequency, low amplitude nystagmus, one eye elevate and intort, and the other eye depress and extort. And by the way, this seesaw nystagmus is not specific to chiasmal syndrome. It can happen with the chiasmal syndrome, but it can happen also with other causes, not only the chiasmal syndrome. But for the exam, they love to bring it with the chiasmal syndrome. Regarding the investigations, again, the gold standard here is the neuroimaging, the MRI, to detect the presence of pituitary adenoma. And by the way, pituitary adenoma can be microadenoma or macroadenoma. The microadenoma or macroadenoma, it will be difficult for the CT scan to detect the microadenoma, but for the macroadenoma, it will be much easier. So if you are suspecting pituitary adenoma, just order an MRI with thin cuts at the pituitary area in order to detect the presence of micro or macroadenoma. Okay, so this is for the diagnosis. For the perimetry, the perimetry can give you clues about the cause and also the location of the lesion. As we mentioned the last time, the location, and it can be if the patient has a mass compressing on the optic nerve, it will cause loss of vision. However, if the mass is compressing at the junction between the optic chiasma and the optic nerve, it will result in junctional scotoma, and in junctional scotoma there will be loss of vision at one eye and compression on the decussating nasal fibers from the other eye, leading to temporal hemianopia of the other eye. It will be upper temporal hemianopia of the other eye if the compression is on the lower nasal fibers. If there is compression on the central part of the chiasma where nasal fibers are decussating, this will result in bitemporal hemianopia. If there is compression on the central posterior part of the chiasma, which where the macular fibers are decussating, this will resulting in central bitemporal hemianopia. And this question appeared in the advanced exams of the ICO before. Left optic, if there is compression on the optic tract, it will lead to homonymous hemianopia. So perimetry here has also a very essential role in diagnosis. Okay, and finally, the hormonal assay. Don't forget that those patients have pituitary adenomas. This adenoma could be secretory. So you need to do hormonal assay, like analysis of the prolactin, of growth hormone, of ACTH, LH, FSH. So these are pituitary hormones that can increase in secretion because of secretory pituitary adenoma. And this also has a role in treatment. So you are not going to treat this patient, of course, but you should know some patients with secretory tumors can have a medical treatment which will save the patient a lot of hazards during the surgery. So for example, those patients who have prolactinoma, those patients can be treated by dopaminergic agonists such as bromocriptine. Or if it will be like non-secretory tumor, or it is other kinds of masses, it will be treated by surgical excision. So this is for pituitary adenoma. There are, as we said before, there is what's called the craniopharyngioma, and the craniopharyngioma is different from the pituitary adenoma because craniopharyngioma will compress the chiasma from above. So it will lead to bitemporal hemianopia more dense inferiorly. On the other hand, the optic chiasma compressed by the pituitary adenoma will compress the chiasma from below, leading to bitemporal hemianopia, which is more dense superiorly. Okay, so this also asked before in the exams, so you need to pay attention to it. So what will be the prognosis? What will be the prognosis for patient with with chiasma syndrome? Well, it depends mainly on the pre-treatment visual acuity, visual field, how much did this mass is compressing the lesion, for how long, and what is the age of patient, what is the duration of symptoms, and what is the severity of the visual defects, of if there is optic atrophy or not, what is the size of the tumor. But the time frame for recovery ranges from early to within 24 hours after surgery, or between 24 to 72 hours after the starting medical therapy, too late up to 6 months to 3 years. So the good thing that you need to know is that that the compression of the visual pathway, whether it is chiasma or optic tract, is reversible. It's reversible in the early stages. So these visual field changes could be reversible in the early stages. If they are treated early, they can improve. And for most of the improvements, they take about 1 to 4 months. Okay. So is it the chiasma syndrome can be a little bit difficult, but I hope that it is more clear now. So, and it has a lot of questions to be asked in whatever exam that you are applying for. Any questions in the chiasma syndrome?